Thank you, Dr.
We are
Amrita.
doing it.
I think there's a slight change in the order, so my talk was designed to
Same.
come a little later. But anyway, I'll start off with this roadmap for ICL, the roadmap for happy patients. I am in the advisory board of Star Surgicals. And even though this is an Australian study which was published quite some time back, there are quite a lot of ethnic differences. And the prevalence of myopia in our population is significantly more, but suffice it to say that less than 0.4% of the general population in this study had high myopia, and 2% of the total myopic population only had
Professor Titialo on dais, please, sir?
High myopia, which is beyond minus 10 diopters. But among the patients presenting for refractive surgery, they constituted 13%, for the simple reason that these patients with extremes of myopia are the ones who are likely to benefit the most from a refractive surgery. So it is said that the moderate myopes are 10 times more likely to present for refractive surgery, and high myopes are 16 times more likely to present for refractive surgery than low myopes. Obviously, these are the patients who would benefit the most from an effective refractive surgical procedure. Obviously, for us, the laser vision correction is the go-to choice as far as correcting refractive errors on a permanent basis is concerned. But whenever you go on to the higher grades of refractive error, then it has the limitations like undercorrection, regression, greater chance of iatrogenic keratoconus, increased optical aberrations, especially induction of spherical aberration, dysphotopsia, loss of best corrected visual acuity, and dry eye. So obviously you need something better, and the TIO, the toric implantable contact lenses, once you use these lenses, outperform laser vision correction in all these aspects, in the sense that fewer induction of ocular high rod aberrations, increase in contrast sensitivity, increase in retinal magnification, improved night vision, less of dry eye, minimal wound healing, faster visual recovery, etc. These has been established in multiple studies, and which leads on to greater patient satisfaction. So obviously, when it comes to greater degrees of refractive errors, maybe doing a phakic intraocular lens would be the the way to go. And what are my indications for phakic doing an ICL? Earlier it was beyond minus 10 diopters. Slowly we are coming down to minus 8 diopters. Hyperopia beyond 3 diopters. Astigmatism anything beyond 3 diopters. And if it is the central corneal thickness is less than 470 microns today, I would not do any laser vision correction. 470 to 500 is PRK, and I need at least 500 microns for me to consider either LASIK or doing even a SMILE procedure. And wherever the patient is very concerned about the quality of vision, there again, the panel discussion has already started. Excuse me, the panel discussion has already started. No, I thought the panel discussion has already started, so. Okay. Okay. So the quality of vision is also where it's important. Then maybe going on to a phakic intraocular lens would be a good idea. And whenever I come across a patient with high expectations, I have been doing laser vision correction for more than 25 years now, and I have come to believe that laser vision correction has a certain lifetime. Even though initially you might get an excellent correction over a period of a decade or 15 years, invariably some amount of power comes back. So if there is a patient with even a -4 with -2 diopters of cylinder insisting on an accurate outcome, I would rather suggest to that patient that he or she could consider a phakic intraocular lens. And as far as the uptake of ICLs are concerned, no patient, hardly any patients comes asking for a phakic intraocular lens. Basically, they come looking for laser vision correction, which they think is a simple outpatient procedure. When you switch them on to something which is intraocular, there's a certain amount of holding back. So you have to reassure them. I tell them that it's again an 8 to 10 minute surgery. I do it bilaterally. They can go back to their work on the next day. And there's hardly any recovery period. We know that many patients, especially for higher refractive errors, when they undergo laser vision correction, it takes them quite some time for the vision to settle down, for them to enjoy their best uncorrected visual acuity. But as far as phakic intraocular lens is concerned, if the surgery is well done, whatever you get on the first day is what the patient lives with till the phakic intraocular lens comes out, maybe for cataract surgery. And this is the way I do my phakic intraocular lenses. Initially, I do not dilate these patients, and you can see this because I do not want my instruments touching the anterior capsule. 3 and 9 o'clock is where meridians is where I do my incisions, and then subsequently it's a 3 millimeter main incision that I am making. It's a real-time video. It takes me hardly a couple of minutes, and then I inject adrenaline xylocaine mixture, which causes significant dilatation, and that's a high molecular weight viscoelastic Helon that's going in. You can see the excellent dilatation that I get with this, and then the lens of my choice, whether it's a toric, almost 70 to 75% of my patients get a toric intraocular lens for the simple reason that even small degrees of astigmatism left uncorrected leads on to significant amount of dissatisfaction among these patients. So no dilatation, there's no irrigation aspiration that's used, and if I am using a toric intraocular lens, toric phakic lens, then there is an overlay of a digital overlay, and all I do is to depress my main port as well as the side port and do a certain amount of irrigation, and you can see the entire viscoelastic flowing in. Flowing out. So there is no irrigation aspiration that goes in, because that is supposed to be the greatest cause for any intraoperative cataract formation. All I do is to hydrate the incision that at the end of surgery. So as you can see that timer put here. It takes me just about a couple of minutes to do this. And whenever bilateral surgery is indicated, I go ahead and do the second eye, switching all the instruments, all the nurse vessel changes, the tray changes, the trolley changes, and the eye is prepped and cleaned for the second eye, and then we go ahead and do the surgery. I do not think we should consider laser vision correction as competitive technology. I think it's complementary. Whenever I come across a great degree of refractive error, I go ahead and implant a phakic intraocular lens to debulk most of the refractive error that's there, and then subsequently do a laser touch-up so that we can get accurate errors. I have handled up to minus 26 diopters with minus 4 diopters of cylinder by the combination of these procedures, and whatever limitations of these procedures concerned, they do not add up. Whatever aberrations are caused by the cornea is not enhanced by once you place the phakic lenses. I think the advantages of these two go together. Another important advantage of the phakic intraocular lens is that because of its proximity to the nodal point, the effective optical zone that you get on the corneal surface is almost 1.25 times. That is, if the optic size of the lens you are implanting is 6 millimeter, what you get on the surface is 7.5 millimeters. Obviously, that's a big advantage because many of these are young myopes who dilate very well in the scotopic conditions, and having something of a large diameter is a good idea. As far as the preoperative assessment is concerned, I do all this, but the most important thing is refraction, anterior chamber depth, and white-to-white measurement. K reading and topography, intraocular pressure, anterior and posterior segment examination, especially there are chamber fluctuations during phakic intraocular lens implantation. So if any lattice retinal tears are there, that needs to be taken care of. Wait for a period of about 4 to 6 weeks for this to scar, and then take them up. Specular microscopy was more of a concern when we were doing anterior chamber lenses, the iris clip. Now it's less of a concern, especially in mesopic pupils when they are large. Sometimes dysphotopsia may be there, but now with the EVO lenses with their larger diameter becoming available, that's again less of a concern. I think the only limiting factor to my mind for implanting a phakic intraocular lens is the anterior chamber depth, and I follow the dictum of at least 2.8 millimeters. And it's extremely important for us to realize that, especially when we come across higher powers, as there is hyperopia, myopia, these are lenses which are thicker in the periphery also, that not compromising this AC depth is extremely important. And PA in the center of flow, some surgeons recommend that if it's 2.6, 2.7, make a peripheral iridotomy and go ahead and implant. But the only time I come to pain with these lenses is when I have compromised on this. And today the strict criteria may be 2.75 millimeters for a small myopia, but anything less than that, better not to implant these lenses. Obviously, you would like to see a picture like this, where the vault is exactly 500 microns of the thickness of the cornea, but there are situations like this. For example, the 137 microns, 86 microns in the fellow eye. But in spite of it, because the anterior capsule remains clear, we have not explanted these lenses. On the other hand, if the angle remains open and even if the vault is about 1000 microns, we do not go ahead and explant these lenses as far as 30 degrees or beyond. But obviously, you have to keep this in mind. When it comes to sizing, then usually it's a combination of keratometry, AC depth, but it's also important to know that if you're using toric lenses in a case of a keratoconus situation, you may get a fallacious reading, for which we reduce the overall diameter of these lenses by about 0.5 millimeter. Horizontal white to white, and I think these things will be dealt to the other speakers also. Mind you, IOL master is not a reliable equipment because it measures sclera to sclera, not limbus to limbus, and might give you slightly larger readings. And another important feature is that in case you have to do a IOL power calculation for a cataract surgery, unlike in laser vision correction, it's really not a complex situation. You can stick to your immersion A scan or your optical biometry and get reliable intraocular lens readings. To conclude, I believe that the roadmap to happy patients with ICLs is good planning, good surgery, and good post-operative follow-up. And in case you do that, phakic IOLs is an excellent tool for correction of all grades of emmetropia.